Thank you very much. I am so excited for the opportunity to be here to talk with you guys today. I am, as the slide shows here, and as Leah kindly introduced, the Director of Outcomes, Research and Development at iCHOM. You've now heard the full length of our company title a few times. I hope you understand why we shorten it just down to iCHOM. So you've seen several of slides today showing this equation. Is anyone keeping tally of how many times it's come up? So it's a really important outcome for us at iCHOM as well. Our mission is to support the adoption of value-based health care around the world. And what value really is here is this equation, the outcomes over cost. As Jennifer mentioned earlier today, a lot of attention in the past has been focused on reducing costs. And there are a lot of great ways that have been doing that, Lean Six Sigma and some of those other activities. But despite those efforts, costs are still increasing and our outcomes are getting worse. And as your neighbor from the South, I can attest to the fact that our costs in the US are the highest for the worst outcomes. So focusing on cost hasn't historically worked. So iCHOM is really focused on outcomes here as the true lever to attaining value-based healthcare. And why focusing on outcomes, particularly those that matter most to patients, another phrase we've heard several times today, is so important. It can be illustrated in this slide. So this is looking at an example from prostate cancer. In particular, it's looking at results from Germany, Sweden, and a best-in-class facility in Germany called the Martini Clinic, which you may have heard a few times. When focusing on standard outcomes in healthcare alone, like mortality here, you see that they all perform relatively the same. If you are a patient looking to decide where you're going to get your care at, where you're going to get the best care at, and you have this information at hand, how do you choose where you want to go? If you are a provider, if you're one of these surgeons doing a radical prostatectomy for prostate cancer, and you want to improve your skills and become better, how do you use that information to do that? If you're a payer and you're reimbursing based on the value and the outcomes achieved for your patients that you're covering, how do you do that with that information? You can't really. But when we look at the outcomes that matter to patients, if we move over onto the other side of the screen, we look at incontinence at a year out after surgery and erectile dysfunction, again, a year out from surgery. You see that this is where the outcomes start to change depending on where you're at, and they're pretty significant. If I'm a patient or a provider or a payer asking those same questions, I want the data on the other hand side of the screen in order to be able to make those decisions. Ultimately, when you measure outcomes, we feel that every stakeholder in the cycle here benefits from it. Patients get to choose their providers based on the outcomes that they want to achieve, what's important to them, as well as their share in the cost savings. Again, depending on the government and where we're located, that paradigm works differently. Clinicians can also improve the quality of care by comparing their performance with others. If they can see, hey, there's someone over here that's doing this a little bit better than I am. What are they doing that it's so different, and how can I learn to do that myself? Hospitals can differentiate into areas where they perform better, so they may reallocate their services for surgeries or other interventions they're not performing quite as well and focus only on those that they are. Payers can negotiate contracts based on the outcomes that matter instead of just continuing the fee-for-service paradigm. And also the life industry can market their products on the value they're really achieving for patients. Are they having meaningful positive impacts for patients out there? So again, outcome measurement here really benefits everybody, all the stakeholders here. By measuring outcomes, what you're really doing is you're putting the patient at the center of care. A couple more buzzwords that are often thrown around here. But this is actually, as we had conversations about before the break, is really radical, revolutionize how care is delivered and how we measure it. So in the typical scenario, where we have intervention, clinician, process-centeredness, care is measured by the specialty. How is radiology performing? How is oncology performing? More specifically, surgical oncology, per se. Care is divided into a series of discrete services, so you're measuring at the level of lab values and tests and those discrete services. And there's a strong focus on the process and structures. So you're not really getting at what's mattering to patients, you're measuring, say, things that are admittedly important, but not getting at the true outcome here. Things like guidelines with medications. Did the patient get the right anti-emetic, basically an anti-nausea medication at the right time, versus did the patient actually stop feeling nauseous? By putting patient at the center of it, though, you're starting to look at measurements across the condition, across the population level. So an example is we have a low back pain in iCHOM. It measures all kinds of different services and modalities for treatment there. Care is organized around the full cycle of care. So instead of looking at a lab value or a test value, you're measuring care over the life cycle for that patient. An example of this is our cleft lip and palate stat. We have measurements over 22 years of that patient's life. And finally, patient-reported outcomes are highly essential to this process, and this is why iCHOM focuses so much on it, and we have our sets centered around PROMs in particular. So what are pros and PROMs? These acronyms have been thrown around quite a few times today, and yet I don't think we've ever paused to quite define them yet. A pro is simply a report of a health status that's coming directly from the patient. It's not being interpreted by anyone else. It's not the doctor saying what I think the patient is feeling or saying. It's direct from the patient without interference. A PROM is simply how that's measured. Now, there are lots of different ways that PROMs are set up. Something as simple as a health diary or a medication log technically is a PROM. It's information about the health status of the patient coming directly from the patient. What's typically used, though, when we talk about PROMs are actually validated tools and instruments. They come in Likert scales, ranked my health is really good to it's very poor. It's typically where we're going here. I also want to throw another term here that I've heard once or twice today is a PREM. I won't be spending much time on this because it's something very different, but just to distinguish it here for us. A PREM is an experience measure of the patient. So it can be things like, did you get hot coffee in the waiting room? Were you able to get a parking space? It's their experience of the healthcare delivery. So there are a couple of different types of PROMs out there. 3 main ones to be specific. When you are looking to implement PROMs in your systems, you're probably going to have to use a combination of these different types in order to really get at what you need. The 3 different types are domain-specific, disease-specific, and generic. If you look at domain-specific, it has a great level of detail, so it has a really great precision. However, the assessment burden, because it's so detailed, is quite high. And what we're talking about by domain here is something like a single concept, so a pain scale. Something as simple as if you've seen the smiley face, the frowny face, I have really bad pain, the happy face is I'm doing okay. That would be an example of a very simple domain-specific PROM. The next type is disease-specific. These are instruments developed around a particular condition. So an example here is the EPIC 26. This is a prostate cancer tool. It asks about urinary incontinence, erectile dysfunction, specifically in prostate cancer patients. So the incontinence questions wouldn't apply to a woman that's gone through childbirth, say. These are really clinically relevant because they're so focused on the conditions. However, you can't compare them to a general population. They're only relevant within the condition area. So if you're a healthcare system and wanting to see not only how patients are functioning within the oncology services, but maybe also have diabetes, you won't be able to compare results across those 2 conditions by using a disease-specific tool. The last type of PROM is a generic PROM. This covers a large breadth of high-level concepts, so it'll cover things like social functioning and physical functioning and mental functioning all in the same tool. You get a very good breadth that you can use across conditions, but you don't get the level of detail. So it's easy to administer from a burden standpoint of the time it takes to do it, but you don't quite get the detail. They're not quite as sensitive to some of those clinical issues around specific conditions, which is why typically you need a combination of these. And that depends, what the combination is, depends on what your actual goals are at measuring. So what goes into developing a PROM? These are just a couple of key concepts. I will admit entirely that developing a PROM is a really detailed, lengthy process, and this is not entirely comprehensive, but to give you an idea of what goes into a PROM. Because PROMs are just as valid as any other medical test. They're just as valid as your blood draw, and they should be taken as seriously as one. This isn't something that, a college student or a university student has written on the back of a napkin. There's actually a lot of science that goes into developing these. So first and foremost is you have a conceptual model. And this is the rationale for the concepts and populations you're including in the tool that you're developing. And what the relationships between those different concepts are. You'll also go into the thought process of how you're going to measure this. Are you going to use a scale? Are you going to use a visual analog, which is the smiley faces we talked about earlier about the pain scale? And you really need to have this clearly defined before you ever start to truly develop the tool itself. The next step is the item generation. So this is how you're developing and finding sources for what are the concepts that are going to go into this tool. There are 3 main sources you can do this for. One is patients, The other is providers, and finally there's also a review of the literature. And what you're looking here for, what are the concepts that are important? Now you can use any one of these three, however the gold standard is actually going directly to patients, doing semi-structured interviews, focus groups. The FDA has actually come out and mandated that all new Prom tools that are developed have patient input early on in the process. So that's really important to looking for. If you're looking to either create your own tool or you're looking to evaluate a tool, look to see how those items are generated. Then comes the item selection. And this can be done a couple different ways as well. One is the endorsement frequency. So how often did this concept come up? Is, say, pain mentioned all the time by all the participants in the previous section on the item generation? Another way to look at this is the item total correlation. This is a fancy way of saying, how much does that concept affect your score for that tool? Something, if you're asking about, say, a prostate cancer tool, and you ask, what's my favorite dog? Not going to impact the score, and you'll see that that item can be dropped. Pretty extreme example, but it shows the point at least. And the other is the internal consistency. How much does the item relate to those other questions? Very similar to that question about the dog. Probably isn't going to relate to all the other items in your concept list, and should probably be dropped. A fourth area that goes into developing a Prom is the psychometric properties. And this is a series of tests that are done. The types of tests specifically depend on the approach that's used. The two main approaches are classical test theory and item response theory. Now, I'm not a mathematician, so I won't go into great detail on exactly what those are, but the classical test theory has been what's been used the most. It's challenging, but easily comprehensible. It's been what's been used to develop all the legacy tools. Item response theory is a little bit newer. You'll see it in some of the new tools that are coming out. It's much more difficult to do, but it's definitely where the field is heading. And it allows you to do more complicated things like CAT, which is computer adaptive testing, which if you're thinking about administrative burden of prompts, it'll let you do things like assume based on one response to a question what the next response to another question is going to be. So for example, if a patient says that they cannot independently lift themselves off a commode, they're probably not jogging around a block. So you don't need to ask the second question, are they jogging around the block? And that's what computer adaptive testing really is. The fifth category here is the scoring interpretations. And this is how are you assessing these questions? So are you adding them all up to get a score, or are you doing some calculations to weight them, etc.? And there are different ways to go about doing that, but then you also need to give a reference point for what those scores mean. So if I told you someone got a 7 on this Prom tool, what does that actually mean? What is a clinician going to do with that number? You have to tie it to something clinical. So 7 means perhaps that they need an intervention, or they need to be hospitalized, or it could mean they're healthy and fine. You need to have those reference points set up. And finally, once you've done that, and each of those processes are iterated numerous times, there are lots of focus groups that go on, there's lots of the psychometric property testing. This happens several different times. Once you finally have a validated Prom tool, you then start looking into the cultural and language adaptations. So this requires a forward translation, where it's translated into the new language, a backwards translation, where it's translated back into the original language. Then you have to have a review with the people that developed the tool to make sure it's still measuring the concepts that they thought it should be. And then you do testing with the patient group. Once the patients have tested it, you do what's called cognitive debriefing with the patients to make sure that they interpreted those questions in the same way that they were meant to be. And finally, once all that's done, the panel of the people who developed the tool again will sit down, review it, and finalize the new adaptation. That happens for every language and also every cultural area. So Spanish for Spain versus Spanish for Mexico, it's not the same thing. You have to do different processes for each of those here. So again, all that goes into, it's a lot of work that goes into developing a Prom. And again, I'll say they should be treated just as much as a blood test is or an imaging study is. They're just as valid and useful for making medical decisions. So at iCHOM, we center our development of core sets completely around prompts. You'll see here, this is our development process. We get an international working group together, which is comprised of clinicians, researchers, and also patients. We mandate that at least 25% of our working group include patients that have lived experience with the condition or the population area of interest. The reason we say 25% is because we have to have an 80% consensus to get anything approved, which means anything that's getting through, patients have signed off on as well. So they're not outvoted, if you will. We'll do lots of breakout groups as well with our patients who sit on both the working group, and also we'll do external consultations to make sure that what we're recommending really reflects the values that patients have here. But once we've selected the outcomes here that value, you'll see in the stars here, we spend 2 calls. So of our 5 content calls, we spend 2 of them on Proms in particular, because this is such a complicated area to dive into. And it takes a lot of discussion. These are our formal calls. I tell you what, in the background, there's also a lot of one-on-one calls and small group calls going on as well to support those. So iCHOM is not in the business of creating new prompts. As I've explained, it's quite a tedious, lengthy, detailed process that we just don't have the resources or time to dedicate it to. And besides that, there are thousands of prompts already out there. So instead of reinventing the wheel ourselves, we look to what is currently best available. And so when we are looking at the hundreds of different prom options for a specific set, these are some of the things we keep in mind. The fit for purpose. Has that tool been used and graded for our condition or population area of interest? If not, probably should set it aside. The tool has to address the outcomes that our working group has included. Again, our working group has said these are the important things, so that tool must measure those things. We try to limit the redundancy, too, of extra questions that the tool may have that our group didn't think was important. They also have to have appropriate recall periods. What we mean by recall period is the time you're reflecting back on to answer the question. So for example, in an acute pain setting, you may ask, how's your pain today? If you're looking at chronic pain, you may be reflecting back on, how's your pain been in the last 6 months? Depending on the need here, we have to have an appropriate recall period. We then also look at the psychometric properties. They have to have a reliability score of 7 or higher. Reliability just means it's free from random error. And if I administer this test repeatedly to same groups or different groups, I might get similar results based on their condition levels. They also have to demonstrate validity. They have to essentially be measuring what it says it's measuring. And they also have to demonstrate sensitivity to change. So if a patient's condition improves, their score should improve. I should see that reflected. We also look at things like the patient experience in this. Tools shouldn't be too long or burdensome for patients to complete. So this is where we rely on our working group members who are patient reps a lot to say, the language on this is really hard to understand. Or we automatically exclude tools that have over 100 questions on them because we're probably recommending a package of multiple tools. Those add up quite quickly. So the total package has to have a reasonable amount of time to completion. Also has to have appropriate literacy levels. You'd be surprised how many tools out there actually have really high, not only regular literacy, but health literacy levels associated with them. Particularly if we're talking about pediatric sets, those change as the patient ages up and how much they can actually respond or are independent themselves. We'll give preference to tools that cover more outcomes. Again, this is a ploy from us to limit how many different tools we have to use. That causes burden on the patient, but also administration to deliver all those different types of tools. So we try to get bang for our buck, if you will, in selecting one Prom tool. We'll also look at administrative burden issues. Again, preference given to tools that cover more of the outcomes our working group has said is important. We'll look at the mode of administration, if it's paper, electronic, if there's CAT, the computer adaptive testing that I mentioned earlier. And we're also looking to see some of these tools actually require quite a bit of administrative training. They'll require clinical calibrations and things like that, which may be barriers to sites picking it up or the tools being used properly. We'll look at the clinical utility. So as a provider, once I see the scores of this, do I know what to do with that? There are a lot of tools out there that actually will just give you a number, but doesn't give you a reference point for what that number means. We want to make sure that this information is actionable, it's meaningful. And finally, we'll look at implementation factors. So we'll look at tools and give preference sometimes to tools that have more languages available. Again, we're an international company, we're looking for international adoption. We'll say that this is one area we do have quite a bit of debate with our working group members about, because you can have a new tool that just came out that hasn't been through so many cycles yet of the cultural adaptations we talked about. It may be a great tool, cutting edge. It's just not quite as available in as many languages. And that's something where I don't have to make the votes in the working group. They have to decide for themselves how they want to weigh that out. They have to be able to be implemented in diverse settings. This could include a rural place that doesn't have electronic IT platforms to support CAT or support some of the electronic communications via emails. So they may just be able to have to do a paper version. That being said, if we have a big system that's going to be using it, they aren't going to have time to collect it via paper and then pay someone to enter it all in. So we need to make sure these tools can be implemented in many different ways. Finally, but not least importantly, we also look at copywriting and licensing issues. Most Prom tools, if you're using them to improve your services or for quality improvements, you can get a waiver to use them for free. That's not true of all Proms though, so we will look into that. Another thing to watch out for is sometimes they'll waive the fee for you to use it, but the calculations to get the score are quite complex and they'll charge you for that. So it's just something else to be aware of as you're evaluating your Prom tools. So finally, all this work has gone into not only creating Proms, but evaluating them. So they better be kind of worth the effort. And I'll end here in a couple of examples of showing that they are really improving patient care and enhancing the value-based healthcare. So this is an example from the University of Rochester. What they did is, for 80% of their total knee replacements, they had their patients create Proms in 3 domain areas. One on physical function, one on the interference with pain, and finally on depression. And what this really did is it put the patient voice at the center of the care. They could compare a patient's preoperative responses with their post-op responses, so they knew how far they had to go to get that patient back to where they had been before they needed the intervention. When you aggregate this up, you can also start to create a roadmap for patients. A lot of anxiety comes from not knowing what to expect from a procedure. Doctor, how long before I go back to work? How long before I can play with the grandkids again? Those types of questions. If you have enough Prom data, you can create a roadmap, not only for what your patients generally look like, but patients that look like the patient sitting in front of you as well, so that they have an idea of how long it's going to take me to get back to these normal activities. And if they're seeing that their data isn't showing that trajectory, they know they can ask their provider about it early and say, hey, according to this roadmap, I should be better than I am right now. What are we going to do about it, doc? It helps facilitate some of those really important conversations. Another great example is coming from partners. So they did a big push to implement Proms in 2012. They very quickly got 1.2 million Prom scores in 75 of their different clinics. This is across 21 specialties. What's interesting here is they saw that not only did Proms help patients, it helped providers. This is also really important too. So the providers here were experiencing less stress, less burnout. Their clinical time, they felt, was spent more efficiently, and they had higher satisfactions in their jobs. And essentially what this was, is before the patient was showing up to clinic, they completed a Prom. So they knew what the problems were going to be for that patient before they ever walked in the door. I'm not sure here what it is here in Canada, but the international average of a visit is 20 minutes. It's not a lot of time to get into it. So if they can walk in with a report and the doctor already knows before you showed up, perhaps even a week in advance, what your problems were, you can have a conversation and use that time to discuss interventions and how you're going to get better. It can also facilitate conversations that normally wouldn't happen. I worked in oncology and prostate cancer quite a bit in the past. A lot of sexual health questions never came up because people were afraid to raise it. If they filled out a Prom ahead of time, though, that awkwardness of initiating the conversation was already done for them, and they knew that their doctor knew, now they can talk about it and didn't feel the need and awkwardness around raising the issue themselves. So a lot of these important conversations that may never happened are happening. And finally, the last example I'll leave you with here is an example from Memorial Sloan Kettering. And this shows that Proms are not only putting the patient voice first, it's not only helping the providers, it's actually having massive impact on real important outcomes. In this case, in cancer care. Memorial Sloan Kettering split their patients randomly into 2 groups, a group that got Proms and a group that didn't. And essentially, when the group that got Proms indicated that their symptoms were worsening after chemotherapy, so feeling fatigue, pain, nausea, those types of things, an email was sent to one of the providers proactively, flagging that. The nurse would then call the patient, they'd have a discussion. 77% of the time, that led to a change in their course of treatment. Ultimately, when we looked at the numbers after the study concluded, they saw that the Prom group, not only did they live 20% longer, but it's because they could also tolerate the chemotherapy for 30% more longer. So just by collecting Proms, not changing intervention strategies, not changing your care pathways, just having early flags to when something is not quite going right, is actually allowing patients to live longer. So with that, you guys have been a great audience. I know it's been a long day, and I'll conclude there, and thank you for your time. It's been a pleasure, and I look forward to hearing your questions.
Hi, thank you very much. When you do Prom in sort of knee replacement surgery, which is very mechanical and directly affected your ability to walk, and compare it to cancer, which is a little bit, it doesn't affect your ability to physical ability to walk like a motor sort of, or part of your body. I don't know if I'm expressing this really right. But I think it's a lot more complicated in cancer. And that's what I wanted to get, is your sense, is it easier to do in something that's more sort of specific and kind of compartmentalized, as opposed to a disease that affects many parts of the patient's life and body? That makes sense?
Yeah, so I think that's a great question. And I don't think proms are unique here in how I answer this. I think generally when you're looking to do intervention, if you have something that's well-defined, an acute phase like a knee surgery, where you have a surgery date and you kind of have an expected recovery date that's pretty clear and short-term, that is much easier to start with, particularly if you're going to pilot something. If you're talking about cancer care, it gets a little bit more complicated. We've also just created a set in overall adult health, which is kind of a primary care setting, much more complicated to try to do that. So if you're looking to get this going in your institution, you need an early success story. My recommendation, as with any other project, not just Proms, would be to start small, something simple, and build that up, roll it out. So that you have the successes. You don't want to crash and burn on something that's super complicated that you're trying right out of the gate. But I think that applies to a lot of projects that you're doing for quality improvement like that.
Louise reminded me I should ask about the question, because I mentioned caregivers, including them in developing Proms.
That's another great question. So when I mentioned patient representatives as part of being the iCHOM group, some of those are caregivers actually. Particularly when I look at sets we develop, like our dementia set. Caregivers are really important. If we look at pediatric sets, having the parent or whoever is the caregiver there involved in those is really important. Some Proms are actually developed to be completed by the caregiver, kind of under the assumption that the patient may not be able to respond themselves in some cases. But yeah, very important to have their perspective in that as well. You'll see in some of our sets too, we have impacts that don't only affect just the patient, but affect the family. So we'll talk about financial burden, we'll talk about social burden, we'll talk about caregiving fatigue, some of those things that do come up. Because when an illness does happen, it doesn't just happen to that one individual, it happens to their whole family unit.
Last chance for questions or comments. Stacie? Okay, thank you so much, Stacie. That was fantastic.